Okay, we're going to go ahead and get started. Thank you, everybody, for joining us today. I am Missy Burgess. I'm the president of our Georgia State chapter of National Association of Certified Professional Midwives, and together in conjunction with the Community Midwives National Alliance, we have planned a Midwife Day for Georgia legislators. I just wanted to give you a brief history of midwifery in the state of Georgia. In 1920, there were as many as 5,000 midwives in the state. They were all Black midwives. And in 1925, the Medical Association of Georgia asked the State Board of Health to begin to supervise these midwives. And by 1963, the state had decided to stop issuing midwifery licenses. By 2002, we had fewer than 15 practicing Black midwives in the state. And ever since then, we all know we've seen a steady decline in maternal and infant health in our state, particularly among the Black community. So what we're here today is to promote the licensing of midwives again in the state of Georgia as a solution to our maternal mortality problem. We have a lot of distinguished guests here today. I did want to acknowledge Senator Tanya Anderson, who is the Madam Chair of the Georgia Legislative Black Caucus. She is here today and available to answer any questions that anyone may have. Any legislators that are here that have questions, you can enter them in the chat if you didn't already submit them, and we're happy to answer those. I'm going to go ahead and introduce Dr. Aviva Rahm. She is our host for today. She's a midwife, herbalist, and Yale-trained MD, board certified in family medicine with obstetrics. She's been bridging the best of traditional medicine with good science for over 3 decades. She's a longtime home birth pioneer and birth activist. Her nonprofit organization, Dharma Moms, provides funding for organizations working toward reproductive justice and birth equity in high-risk obstetric communities. Her online programs for women are wildly popular and successful, helping women take back their health affordably, and her innovative professional programs are educating a next generation of health practitioners. Dr. Rahm lives and practices medicine in the Berkshires and New York City, and we're happy to have you today.
Thank you so much, Missy, for introducing me. In 1985, a young mother studying to become a home birth midwife began working as a volunteer for her county's Department of Health, creating curriculum to prevent unintended, unwanted pregnancies. At that time, she learned that the infant mortality rate in her state was amongst the highest in the nation, as was the maternal mortality rate, and those rates were significantly higher amongst Black women. That same young mother in 1988 created the plans for a maternal health mobile with the support of Atlanta University's Black Family Project and a medical advisory board that included a physician and master's in public health working at the CDC as director of infant mortality. The mobile was to be staffed by community healthcare workers, including midwives, willing to go into Atlanta's and rural outlying areas most needy and most underserved communities to provide prenatal care. Simple nutritional counseling, hands-on, and blood pressure checks, for example. She was told by the Department of Health that midwives were a relic of the past, that there was no chance midwives would be reinstated in Georgia, and good luck. As a result, the project was unable to take root. That young mother became a home birth midwife, trained by traditional Black midwives in Georgia, and practiced home birth for 20 years against legal challenges in her state, and went on to become a physician, to be a bridge for mothers seeking safe, relevant, and reliable choices in maternal health options. It's 35 years later. That mother now has 4 grown children, all born at home, one a major public health figure, running an organization providing care to over 70,000 high-risk families, largely Black and Latino, in 5 states. He states that his work was inspired by growing up in a home where awareness of health disparities and the role of midwives in addressing those was central. It's 35 years later, and that mother has midwifed her own grandchildren at home, including those of her Harvard-trained pediatrician and master's in public health daughter-in-law. It's 35 years later, and the statistics in that state have not changed, nor has the status of the very care providers who care enough and are well-positioned to make a difference. That young mother is now me at 55, not only a midwife, but taught by some of the very same midwives hosting this event, and a Yale-trained MD with a specialty in family medicine with obstetrics. And that state is Georgia, and the issues facing mothers in Georgia remain pressing. Georgia remains in the bottom 6 in the U.S. for infant mortality rates ranked by the CDC. Georgia ranks amongst the worst in the U.S. for maternal mortality at 48.4 per 100K per recent statistics. 70% of pregnancy-related mortality is due to preventable causes, including cardiomyopathy, cardiovascular disease, and Black women are 2.7 times more likely to die in childbirth than white women. It's time for a change. The tradition of midwives as care providers goes back to the very foundation of this state, and it wasn't lack of quality or competence that drove midwives out of work. It was part of a systemic campaign to discredit and disenfranchise midwives, most of whom were Black and serving white and Black families alike, rich and poor alike, in cities and rurally. The elimination of the midwife in the state of Georgia has not improved maternal or infant health. In fact, it has left untold numbers of women around the state with no access to maternal health care or easily accessible prenatal care or birth services at all. In fact, an astonishing 79 of Georgia's 159 counties do not have a single obstetric provider. 8 rural Georgia hospitals have shut down at least since 2010. More than 80 of the state's 109 rural counties are designated as workforce shortage areas in terms of both primary and specialty care. In rural Georgia, 83% of women must travel outside of their county to deliver, sometimes an hour away, sometimes facing things like extreme hypertension on the way to maternal health care, and some may need a further transport after that to a city hospital or a more equipped hospital. Half of all births annually occur in rural Georgia. Distance to care has become a serious problem. Midwives can fill this gap, are willing to fill this gap, and do far more. Statistically, countries with midwives integrated into their care systems, including our neighboring Canada, with access to seamless transport and a backup service that is reliable, have amongst the lowest maternal and infant mortality rates in the world, and higher satisfaction of women with their birth experiences, which translates into better infant care and better maternal mental health after birth. Midwives are cost-effective, and there's already proof of concept of their safety and efficacy as providers, as well as access to training and a national certification that could be easily adopted by the state of Georgia. And midwives can bring their services into communities most in need. One question that comes up is, well, what about high-risk mothers? They can't really use midwives, can they? Well, right now, those mothers in many counties are getting no care at all, including the simplest of blood pressure checks that can be life-saving prenatally, during labor, or postpartum. Moreover, and importantly, midwives have been shown to help women at high risk remain low risk and to mitigate the risk of those in higher risk categories. It's why, as a physician trained in hospital birth and a home birth midwife with over 20 years of experience, I remain an ardent advocate of both a woman's choice for her place in childbirth and also the significant role of midwives in the public health and medical system. I want to thank the Georgia Community Midwives for inviting me to host this panel and for the work you're doing on part of all mothers and families to reinstate midwives as part of the Georgia maternal and infant health care system. And I want to thank our 3 speakers on this panel, Senator Lester Jackson, who is the sponsor of Bill 111 for community midwives, which would provide for the licensure and regulation of certified community midwives and create a certified community midwife board. Senator Jackson will speak from a policy point of view, how community midwives can save lives and money. Midwife Jenny Joseph, who has a phenomenal training program and midwifery center in Georgia, who's going to speak on training and transition to licensure and access in states, about starting a midwifery school and why we need more Black midwives and how to achieve that. And Dr. Ramani Kelsey Rogers, a family physician who also had her baby at home, who will speak about her reasons for choosing a home birth, why as a woman and as a physician she would do this. I'm actually going to, we're going to have 15 minutes for each speaker and then 10 minutes for Q&A. And then we have some extra fun videos and wonderful things at the end of our panel time. I'm going to start with Dr. Lester Jackson, Senator Dr. Lester Jackson III, who is a resident of Savannah, Georgia, is a state senator representing the 2nd Senatorial District of Georgia. Before being elected to the Senate, he served 5 terms in Georgia House of Representatives. He's the author of several landmark legislations, including the Hale Crime Bill, which makes hate crimes illegal in the state of Georgia. Chairman Jackson is a proud veteran, serving 7 years in the United States Navy. Professionally, Dr. Jackson is a cosmetic dentist and CEO of Atlantic Dental Associates. Dr. Jackson is a 1985 graduate of Meharry Medical College and an alumnus of Payne College, where he currently serves as vice chair of the trustee board. He's married to Dr. Lorna C. Jackson and the father of 4 children. Senator Jackson, thank you. And Senator Jackson supports midwives, and his own mother had her babies at home. Senator Jackson, thank you so much. We're just honored to have you here with us today.
Good afternoon. I'm State Senator Lester Jackson. I'm so honored to be part of Midwife Day at Georgia State Capitol. Before I begin my presentation, I would like to make 2 small presentations to acknowledge some outstanding people that's with us today. I would first like to acknowledge Ms. Salama. If you could come forward, please. Ms. Salama has been a practicing midwife for 40 years. But what impressed me about her is not that she's a practicing midwife, but her commitment to community, her commitment to service, and her commitment to make this community a better place. And once I saw some of her writings, she believes in the words, if you teach a man, you teach an individual. But if you teach a woman, you teach a nation. So Ms. Salama, on behalf of the state of Georgia, I have it before your commitment to mothers, to your commitment to children, to accessible to so many people, not only in Georgia, not only in America, but throughout this world. The state of Georgia is hereby would like to acknowledge you as one of our outstanding citizens for your contribution to Georgia, for your contribution to make this place better. So on behalf of the state of Georgia, we would like to not only thank you, but commend you for your hard work and commend you for being the face of midwifery throughout America. So thank you for your dedication and service. Thank you.
Thank you,
Okay?
Senator Jackson. Thank
You're
you
quite
so
welcome.
much.
Come right here and just. Thank you. Thank you. And midwife is important to me for several reasons. My grandmother was a practicing midwife for over 45 years. And she loved the idea of not only delivering, but providing quality health care. And you don't know the people that you touch when you're a midwife. You don't know what a difference it makes. My next presenter is Mr. John Jackson. Mr. John Jackson was not birthed in Georgia, but he hails from Texas and then lived in Nashville, Tennessee. And now he lives in DeKalb County, where he is the chairman of the DeKalb County Democratic Party. But what's unique about Mr. Jackson is that 35 years ago, he was birthed by a midwife in Texas. But now he's in Georgia. He was a part of the key people as chairman of the DeKalb Democratic Party. He got the vote out not only in DeKalb County, but throughout Georgia. And he was instrumental in making Georgia blue and making Raphael Warnock senator and John Ossoff, our U.S. senator in Georgia. But what that did was that turned the Senate that turned the Senate 50% Democrat, 50% Republican, and made Kamala Harris the deciding factor in changing America. So because of his hard work, Mr. John Jackson, we would like to bestow upon you to make you an official ambassador of the Georgia State Senate for your hard work, your hard dedication, and your commitment. And I'd like you to say a few words about what midwifery means in Georgia and especially in DeKalb County. Thank you, Ambassador of the Georgia State Senate, Mr. John Jackson.
Thank you, Senator Jackson. And I want to say to all the midwives out there, thank you for the work you do that is making safe and healthy childbirth accessible to people of all economic levels, of all geographic locations, of all racial and ethnic backgrounds. As someone who was delivered at home by a midwife myself, I understand the important role that you play in our healthcare system. And we want to do everything we can to make our system more inclusive. And one of the things we can do is elevate our midwives. So I want to say thank you. Thank you for your hard work. And thank you for being here today.
Mr. Jackson, thank you very much. Ms. Abdul Salam, thank you for your commitment to serve this great state. I'm here today to tell you that midwifery is important, not only in Georgia, it's important around this country. Not just the practice of midwife, but the commitment to provide not only education to young mothers, but to provide a safe method of delivering babies at home in a safe environment, and also access to healthcare in rural Georgia. And midwifery does all of that. I introduced Senate Bill 111 this year to legalize the practice of midwifery. As you know, midwifery was legal in Georgia for many years. In 1992, we have changed the law, and we made the law a little gray, and so we have to go back and reassess where we are when it comes to midwifery. Midwifery is very important when we're talking about access to health. There's no one who knows about delivering a baby in this world more. No one does it better than midwives. I know this growing up in Alamo, Georgia, where my grandmother did it for nearly 45 years. Her commitment to excellence, her dedication to duty, and the service that she gave not only to the Wheeler County community, but the respect that she gave, the respect that she was given made her a pillar in the community. At that time, physicians didn't have access. There were not a lot of physicians in rural Georgia, and physicians to every birth. In addition to that, African Americans were limited to hospital access. So, but in the 21st century now, midwifery plays an important role. Can be the answer to healthcare access and into rural Georgia. Senate Bill 111 was not my first introduction to midwifery. We've been introducing midwifery legislation to impact the lives of Georgians, to impact the lives of families for the past 4 years. And we are steadily moving forward. More and more legislators are getting on board to talk about the practice of midwife. And we are encouraged to make this country better. We are encouraged to make our state better. And to do that, we need healthcare professionals that's on the front line. We need them to not only be legal to practice their profession, but we need to make their profession accessible to more Georgians. We had a healthcare crisis with COVID-19 and many other elements that's going into our hospitals. Our hospitals are filled with people that have other illnesses, and we don't want pregnant women to be exposed to the ills of hospitals. And I feel that midwifery or or the delivery of a baby is not a medical procedure. It's a natural process. And midwives have been doing it in America for over 400 years. So we want to continue that course of treatment. Let midwives continue their profession and not be led to be disenfranchised from practicing their profession in Georgia. So I'm a proud sponsor of this legislation. I'm a proud supporter, and what I can do to give more people who need to have a safe delivery at home, I'm willing to do so. Me and my colleagues stand ready to expand expand the practice of midwifery in Georgia and give them a license to make midwifery not only acceptable, but make midwifery legal in our great state. So I'm glad to be a part. So thank you for giving me this short time to be here. Now I'm available for questions. Thank you very much. I'm Lester Jackson. I represent Savannah, Georgia, but more importantly, I represent the disenfranchised and the voiceless, and I stand ready to help you. Thank you.
Senator Jackson, thank you so much. Thank you for honoring Salama. I met Salama when I was 18 years old. She stayed at my house and shared some wisdom with me that has stayed with me for many decades now. And it's so important to honor the midwives who we have trained with, for honoring your grandmother's legacy. That's so beautiful. And for your commitment to the disenfranchised. How would you like to handle questions, Missy? Do you want folks to just unmute since we have a small group right now?
Yes, unmute would be fine, and I stand ready.
Okay, perfect.
Mm-hmm.
Well, I'll start with a question to break the ice while folks are formulating their questions.
Mm-hmm.
Senator Jackson, what do you feel is the biggest obstacle to encouraging or swaying your colleagues to readily reinstate midwives, and what can we do as the midwifery advocates and the midwives ourselves to help that along?
Well, the fact is there's so much misinformation when it comes to the education of midwives in Georgia. There is a lack of education of the legislators. They don't know that midwives have done so many hours of not only training, but have done so many classwork hours and commitment to book hours too. In many cases, it takes 3 years to become a midwife, far less than it and far less in other professions. So legislators don't know the training, the hard work, and the dedication it takes to become a community midwife, and so what we have to do is we educate legislators, training that community midwives have to let them know that it's safe, and not only that it's safe to the mother and to the baby. It costs our government a lot less money. It saves dollars when it comes to healthcare.
Hello, I have a quick question.
Yes, ma'am.
Yes, this is a Representative Angelica Kauscher from House District 50. So sorry, I'm in the car, so I have to pay a little bit attention to the road, but
please do.
I will. I'm originally from Germany, and my kids were born in Germany, so I have very high appreciation of midwives and their abilities to help women pre-birth and the postnatal care. It is very important, especially to really make sure that women have the guidance they need to stay healthy, that the baby stays healthy. It helps reduce maternal death numbers, but also it's a very practical issue. And you talked about the cost. So my question is, I understood here. I'm not quite sure how midwives are being used or used is probably the wrong word, but put to work in Georgia in the United States. So there is the thinking that this is only for home birth. But when we're talking about reducing costs for medical care, I think putting midwives into hospital is actually being in charge of the birth until the situation becomes one where a doctor had to interfere would actually also be very beneficial for the overall care in mothers and for the overall health system. This is actually something they do in Germany, that the delivery is done by a midwife until the situation comes that the doctor has to interfere. Because quite honestly, I always say women have given birth for hundreds of years or thousands of years, and that didn't change. And it's not a disease or an illness, but it's something that needs protection, because one of the risks is mothers dying in childbirth or the babies dying. So we need to protect everybody against that. But so I would like to have the discussion really of the overall benefits of health benefits for everyone in utilizing midwives in the overall care for young mothers.
Well, ma'am, thank you for your question. Childbirth is considered a medical procedure, and most of the world, childbirth is not a medical procedure, but it's a natural body procedure. The delivery process, you don't need a physician to be present for a delivery process. As you stated, midwives has been doing this for thousands of years, delivering babies without a physician, quote. And somehow our country has transformed the delivery process of a woman's delivering a child, has deemed that a medical procedure, and it's not. We need to re-educate the public and let them know that childbirth is natural. Childbirth is natural, and with the natural training, with the training that midwives do, they can do it safe. They can do it in a safe environment, and an environment that is cost effective, and in an environment that gives the mother and the child ultimate protection. Many of you don't know that the mortality rate of women, Georgia ranks number 50. The mortality rate of infant death, Georgia ranks number 50. We need midwives on the front line so that we can reduce the mortality of midwives, not only in rural Georgia, but also in urban Georgia. We need midwives legal on the front line to protect mothers and to protect children. Thank you for that question.
If I may, Senator, add a thought. Is that okay with you?
Yes, ma'am.
One of the challenges that midwives have faced in Georgia, including the nurse midwives, which are sort of the equivalent to what the hospital midwives are in Germany, there's a little bit of a hybrid, actually. In Germany, the midwives don't have to become nurses first. They're direct entry. Here, we're sort of bifurcated. You either have the typically home birth midwife who's gone through a direct entry route, or the certified nurse midwife who may practice at home, may practice in a birthing center, and may practice in a hospital. The challenge is in Georgia historically that the way that the laws have been set up, midwives, even the certified nurse midwives, have been prohibited for attending home births in Georgia unless they have an OB who's willing to oversee them. There were decades when I practiced in Georgia where there was not one single OB in the state that would support any nurse midwife to attend a home birth. So the nurse midwives who do exist are limited. And also, due to a lot of complex factors that have to do with how we define risk, which often end up putting women of color, particularly Black women in high-risk groups, often those women become risked out, as we say, from having their babies in lower risk settings like birthing centers or with midwives, because once you reach a certain age, weight, blood pressure, many factors that are challenging the Black community, you can't work with a midwife anymore. And so that also needs to change, because it's midwives that can actually help reduce those risk factors for all women.
You are correct. Senate Bill 111 pays particular attention to direct entry midwives. And it's the direct entry midwives that need support from our state. And they need, and as legislators, we're not doing it to help direct entry midwives. We're doing it to help families that want to have a safe pregnancy and a safe delivery in their homes, with professionals that can do this process, but also do it economically, do it safe, and do it in a loving environment around family and friends. So thank you for your question, and you're right. There are many layers to midwives. I found this out, and I understand the idea of the nurse midwives, and they have a role, the role of midwives that practice in the hospital and at home. Our task is to re-educate gynecologists and to have them embrace the idea of assisting direct entry midwives to carry out their profession and their God-given duty to protect women and to protect children.
There are also states that have already taken the step to license and certify midwives that do allow those midwives to have seamless privileges into hospitals too. So it doesn't have to be completely polarized like the home birth direct entry midwife at home and then that's it. And there are many states where home birth midwives can utilize IV therapy and emergency therapy to stabilize women who live in rural communities and need to get to hospital, which is a really big issue in Georgia, and then can continue their supportive care in the hospital, either as a midwife or as a support person if the OB needs to take over.
And this is just not in Georgia. There are over 32 states in our nation that either have legislation to give language to permit direct entry midwives and for practicing in their state, or they already are licensed to practice in their state. So it's already on the books in 32 states, or there's legislation pressing now. So this is not just a Georgia matter. It's a matter that's affecting Americans and states all over this nation. So Georgia's just one little area, but the fact that Georgia ranks number 50 in the mortality rate poses particular concerns. And we as legislators, we as citizens, we need to advocate for the lives of mothers that are critical, that their lives are critical, that we rank 50th in mortality. We need to do more. And this is one step that we can save lives in Georgia.
If anyone's just joined and has a question for Senator Jackson, please feel free to unmute yourself and ask away.
And remember, it's just not me. Several other legislators have signed on to Senate Bill 111. I need you to look them up, thank them for their commitment of saving lives, but also encourage the senators that and House area in your districts, call them, send them emails, send them texts to encourage them to come on board to saving lives, decreasing the mortality rate in Georgia. Part of this movement to move America forward. Well, just thank you. I'm just honored to be a part of this celebration of Midwife Day at your state capitol. Remember that this battle is not for midwives. This battle is to save lives in Georgia. So keep up the good work. I think we're going to be successful. Hopefully that more members of the Georgia General Assembly will come on board and we can make this happen this year. The direct entry midwives legislation to make it legal in Georgia. So thank you. Tune in, follow us on Facebook, look for our emails coming. We're going to make a movement to change lives in Georgia, to protect families, to have to reduce more mortality and to promote healthy births in our great state. So thank you. I'm Lester Jackson. It was indeed a pleasure to be a part of this wonderful celebration at your state capitol. Thank you.
Thank you so much, Senator Jackson, for joining us and your work and your commitment. And, we're just going to be here behind this happening too. So thank you so much.
Thank you.
Our next panelist is Jenny Joseph. And amongst the midwives in the United States and the world, she is quite a hero. Jenny is a British trained midwife who fights to ensure every person has their healthiest possible pregnancy, birth, and postpartum experience with dignity and with support. Jenny created the JJ Way, which is an evidence-based maternity care model delivering readily accessible, patient-centered, culturally congruent care to women in areas that she terms materno-toxic zones. Her focus and drive is to ensure that Black women and other marginalized people remain safe and empowered inside broken and inequitable maternal health systems that have become dangerous and all too often lethal. She is the executive director of her own nonprofit corporation, Common Sense Childbirth Incorporated, which operates a training institute, health clinics, and a birthing center in Orlando, Florida. And she is also the founder of the National Perinatal Task Force, a grassroots organization whose mission is the elimination of racial disparities in maternal child health in the USA. In July 2020, her school, Common Sense Childbirth School of Midwifery, became the first and only privately owned, nationally accredited midwifery school owned by a Black woman in the United States. Jenny is the founder and a proud member of the Council of Midwifery Elders. She serves on the Advisory Council for the Congressional Black Maternal Health Caucus and is a fellow of the Aspen Institute. Jenny, it's an absolute honor to welcome you and introduce you.
Thank you so much. I appreciate it, Aviva, and thank you, Dr. Jackson, for having me here and everybody else for joining today, celebrating Community Midwife Day. This is my second year. Last year I was at the state capitol with you all to be able to celebrate it in person. And of course, this year, as we are hopefully coming up out of this awful pandemic, which has completely devastated so many of our lives and our lifestyles, I'm just really present to the fact that although we are now facing and managing a COVID-19 pandemic, we've been in a pandemic of racism and disparities amongst mothers and babies in the United States, particularly for Black and Native women and their families. To me, this has been an interesting journey. I arrived in 1989. I came from England. I was born and raised there. My parents are from Barbados in the West Indies. And I grew up and was trained as a midwife. I've been in midwifery for my 40th year this year. I got off a plane in Orlando and I thought, well, let me go get my job. I'm going to work at the hospital. I'm going to deliver babies. That's what I've been doing for the past 10 years. I know Americans have babies. Oh my goodness. The wake-up call. And even now, 30 years hence, I'm still reeling from the understanding of the complete difference in how maternity care is handled here. When Representative Koch raised a question about how things are in Germany, I can relate to that. I'm accustomed to midwifery being the way that maternity care is delivered and supported in every country that I've ever been in other than this one. I'm also accustomed to the fact that health is a human right. I'm accustomed to the fact that access to healthcare is a human right. And when we look at how we have and continue to treat women and children, particularly women of color, in terms of how these outcomes stand year in and year out, decade after decade, it's unconscionable and it will not be allowed to continue. It is unacceptable. The workforce that can address this better than perhaps any other provider in this space is the midwife. The midwife is a community embedded, a community trusted, a community chosen provider who can deliver care in a way that is not possible when you have vast and massive systems where people are not connected, where there isn't time for that compassion and human kindness that is the bedrock of midwifery care. I've been in Florida since I arrived. I haven't lived anywhere else. I'm in Orlando, but I do have an office where I see patients who are choosing sometimes to deliver in the birthing center environment, sometimes in the home environment, and many times in the hospital environment. But as a midwife, I'm able to provide prenatal care, postpartum care, and what we call interconceptional care for them. I also train other people to do that. I also train community health workers to do that, doulas, childbirth educators, and lactation. Perinatal health is a team event, and the missing team player in Georgia is the midwife. The midwives that have been eradicated, that have been lost historically, who were the bedrock of their communities, they need to be replaced, and we will see the sea change that brings. We will see that the outcomes are going to be so vastly improved and so readily improved. It's not rocket science. The most cheap and cost-effective way to do any form of healthcare is actually free. It doesn't cost any money to be kind. It doesn't cost any money to respect who you're working with. It doesn't cost any money to maintain and support their dignity. That's what midwives do. So I'm really grateful to be here. It touched me too to see and have Salama have that honor received from Senator Jackson, just to know that there is that same ability that we've always had to honor and revere our elders, to respect them, and to follow their lead, because that's how we do midwifery. We pass on our skills from generation to generation. We know that we need to build a pipeline of healthcare providers who are going to address our new normal. Yes, this pandemic will go away, but our disparities won't go away. Our outcomes won't change if we don't make an effort, a conscious effort to address them. So I applaud Georgia for this lead in bringing community midwifery back to the center of your communities. I thank Senator Jackson for his work and his leadership in this cause. And I think it's so poignant when we point out, oh, this person was delivered by a midwife, or that person was delivered by a midwife. All of us are born. We will always be born. And someone has to attend to the birthing of our, when it's our time to come earthside. So I'll wrap up my comments with saying, I'm here for this. I support this. I'm grateful for the work and the leadership in Georgia, because there's still too many states that don't even have what you have, don't even have language to work with and move forward. There's a need across this nation for us to get up to speed with the rest of the world, where we know internationally midwives manage maternity care. Midwives are the genesis for safe and healthful births and outcomes. And indeed, mothers and babies are saved when we center midwives back into our communities. So thank you. And I'm happy to take any questions as well.
Jenny, before we open to general questions, would you be willing to address some of the ways that the legislature might feel confident or comfortable in midwives once there is accessing education that they can feel good about? And this is something you've been very central in midwifery.
Yes, I think it's really important, and Senator Jackson alluded to that. Midwifery training is on average a 3-year training. The purpose of that length of time is to not only have the hands-on experience and to build competencies into the practice, but also to put the didactic and academic thoughts and reasoning behind why that practice is so important. An important part of good education for a midwife involves collaborative care, understanding how to work inside of the healthcare continuum, to be interdisciplinary in their work. The midwife is the guardian of normal, but the midwife also needs to be adept at understanding abnormal complications and when there's a need for help, when there's a need for intervention, when there's a need for collaborative care for the safety of the mother and the baby. We have a minimum of 50 births that must be done before a midwife is eligible to graduate and to be able to practice independently. We also have strong mentoring systems embedded into our education. We use a typical type of apprentice model where midwives are with more senior midwives and the students get more hands-on experience and are able to really be strong in their competencies. Our school, for example, in Florida is based off of the International Confederation of Midwives standard for education. This is obviously a worldwide standard and is held very strongly. And we know that the accreditation that we've received for our school means that we meet those standards. And so nationally in the United States, we have standards for midwifery education. But remember, a community midwife, a direct entry midwife, is the only midwife who's trained in the specific need to provide care out of hospital. And that's important. And I'm going to mention the pandemic again, because in disaster preparedness, we want everybody to know how to do births and to support pregnant women and postpartum and breastfeeding women. Midwives are going to be already in place as we move forward in this new world, in this new normal, where we don't know if hospitals are always going to be available. So this is the first responder of maternity, if you will, and the training and education needs to match that so that there's always safety, monitoring and standardization in the practice, even though we acknowledge and embrace traditional and other holistic approaches to the Midwifery Act, Practice Act. So I think it's important that everyone understands that what we're talking about here is codified, structured, overseen, organized, and safe. And there's accountability to that through licensure and putting practice acts in place, as well as allowing midwives to earn a living, which is also important, that there's recognition for the skill and their certificate and their accreditation, and that they can be reimbursed from Medicaid, from commercial payers, and that they are considered part of the medical hierarchy because they do work in that way.
Jenny, additionally, one of the things that has always really struck me as a home birth midwife is the fact that the illegal status of midwifery actually decreases transports that need to happen. There's a lot of complication that even some of the concerns that people have about home birth and midwifery really have more to do with the fact of lack of access of those midwives to easy, seamless transport and those mothers to easy access when the system is polarized. Can you address how licensing and certifying midwives in a state can even augment the safety of home birth?
Absolutely. I think this is what Senator Jackson mentioned earlier, that this isn't about midwifery per se. This is about the people in the state who need the protection and access to safety, which they don't have right now. In the absence of midwifery, in the absence of community providers, in the fact that rural counties in Georgia are bereft, are left literally without anything, that what we have is an opportunity to break down those barriers that have up to now kept let's say the warring factions, being obstructing the progress and the chances for midwifery to grow and develop. So historically, the medical tension, if you will, between physicians, hospital systems, and other types of providers, feeling some maybe territorialism, some competition. As we realize at the end of the day, it's the mothers and the babies that are suffering. It is intractable, it seems. These statistics on maternal morbidity and mortality, infant mortality and morbidity, They cannot be changed unless we are all of us as in concert, ready to move forward and say, we'll let go all of these other reasons, barriers, excuses, dramas that we have in play that are literally, in my opinion, lethal to the people that we claim to care about. If we are really invested in women, in babies, in health, if we really care that this number of women are dying in a developed nation now, we're not talking about underdeveloped nations or lack of resources. If we are going to have any impact on the outcomes, we must come together from that stance of working together, working collaboratively, bringing everybody's best piece forward so that we can all see how, as a team, we are so much more effective, so much more efficient. And again, I consider this is a human right. If we were talking about a developing nation, we'd have all kinds of solutions and all kinds of willingness to collaborate, even find money and get ourselves over there to fix it. And yet we continually, year in and year out, throw our hands up and say, we don't know what to do. Yes, we do. We know exactly what to do. We just have to have the will to do it. And at this point, every time we hear another statistic, every time we hear another mother lost, every time there's a news article about how somebody has suffered through this experience of childbearing in the United States, we have to ask ourselves, how long? How much more are we going to put up with before we get together, put our heads together and make this work?
Does anyone have questions for Jenny? If you do, please unmute yourself. Feel free to ask her. We have time for some questions for sure. And Jenny, thank you. I'm moved and inspired.
Yeah, this is Representative Kausch again. And Jenny, it's so sorry.
We can hear you.
Oh, okay. So, Jenny, so thank you so much for your great input in what we would have to do or could do. My question for you is when we talk about midwifery in the US, and the system is set up as Senator Jackson said, is like that we defined at one point birth as a medical condition, and one of the things that's probably happening is that physicians, OBGYNs, are trying to are kind of like bound to a certain standard they have, because then the question comes, who's going to pay for it? And with midwives not being really in us, that it in the end negatively affect women's health.
Representative Kausch, we're having some trouble hearing you.
What are the best ways to change? There's a lot of education, but we not only. Oh, I'm sorry. I must be in the hole right now. So
yes, I get the gist of your question, and I would love to answer that question, because it is simply about the mindset that we have in the United States around. Well, I think it's, again, this whole idea that because of the commercial aspect, let me put it that way, of medicine, and the commodification of certain procedures, etc., we have created that maternity is a business, and that's the hard truth. So the number of dollars that are changing hands in the billions are over maternity care. The most common reason to be in a hospital at all is because of maternity care. So we have that system that is in place already, and it's a capitalist system which has to continue to run as a business. Having said that, we also now have a public health system, an issue that needs addressing. So it's a matter of looking at how we marry both, because the system is what it is. People who work inside of the system, I think, know that they would like to see changes, but are hard put to figure out the solutions to those changes. So as we go forward and can look at how community-based providers, community organizations and practices can work in tandem with the medical system as it stands, come alongside of that system without necessarily disrupting that system or trying to be competition to that system, but rather working hand in hand because we have a crisis. Okay, so just like now we have COVID-19 and we have all these new ideas and reasons, money and funds and supports to handle COVID. I suggest that what we're doing now is the beginning stages of working in the same approach. How do we handle maternal child health and the disparities and poor outcomes that have plagued this country for too long? If we want to work together, which I suggest we can do that with understanding and respecting each other's ways of being while still solving the problem, again, for who? The patients, the mothers, the babies. Our issues are going to have to be put aside and we're going to have to be creative. But if you notice, since COVID, access is now becoming much easier for any and everybody who up till now didn't have it. You can find a way to get your vaccination. You can find a way to get your support, your test or your treatment. This is because we've had to react to the crisis. Well, there's a crisis in maternal child health and it is continuum and it's decades old at this point and we must act.
Jenny, can you address the increased demand on midwives since COVID, particularly for home birth? I mean, I know that even in the very earliest days, midwives were getting 20, 30, 40 calls a day and were booked far out. So it seems to me that you talked about a really important issue of midwives being the first line of maternal health, the first responders, and yet we have a shortage of midwives. So there's a really critical need right now for this bill to pass and the status to change.
Absolutely. This is why we have become really intentional in training midwives from communities of need. Our school specifically is pushing for getting midwives of color into midwifery training and out the other end, marginalized people from marginalized communities who are willing to go back in and service those communities. So just like over the years, you know, we've had federal programs for health shortage areas and for, you know, loan forgiveness, etc., these kinds of incentives. We also need to make this massive push to get midwives on the ground because midwives aren't just delivering babies. Don't forget that. Midwives are providing prenatal care. They can run clinics. Midwives can do postpartum care. If we expand our Medicaid out for 1 year postpartum, the midwives are likely to be the providers. Who else is coming? So we must fill this workspace right now. This is a workforce development piece, as well as a community health piece, as well as a public health piece, and as well as a professional and recognition and allowing people to come out from under the shadows to practice safely and with support, but with that recognition that we must build this pipeline. It's urgent that we do that. And over the next 10 years, we need to see a growth of midwifery across the United States, but essentially, obviously in Georgia, given the shortage, the dire shortage of providers in the state.
And while Bill 111 is not specifically for the promotion only of Black midwives for Black mothers, you do mention the importance of Black midwives many times. And I want to really emphasize some statistics that have come out in the past few years. One, for example, we know that Black babies that are cared for by a Black medical provider are significantly less likely to die than Black babies cared for by a white provider. Can you address the importance and the outreach to particularly Black midwives and midwives of color?
Yes, I think our statistics keep telling us what we just need to open up and listen to. When 3 to 4 times as many Black women are dying during childbearing, or you know, how many tens of thousands are nearly dying that we don't know how to count those numbers. Nearly dying is horrendous too, and shouldn't happen around a natural event. The matching and the congruence of providers to the mother, family, community seemingly makes a difference on an intangible level that we can't even really, there's no science for that. But what we can do, all of us can consider how we felt when, say, a nurse with compassion or a physician provider with compassion did something for a family member or for us, and how that touched us on a level that's hard to measure, touched us on our spirit, our soul, our heart, in our person. So if you think about what grand midwives, the so-called granny midwives, did many decades ago, they were that embodiment of that ability to have you feel the healthcare as well as receive the healthcare, have you feel centered and embraced and cared for, taken care of. So what we know is that we want to create a workforce that is that continues to stand for that operates from that, as well as has these skills and competencies to provide the care. So in any healthcare discipline, we always can point out who stands out as extra compassionate or extra caring, or who listened better, or who responded with heart and kindness. That in any discipline of medicine is always recognized and appreciated. Listen to the stories of the mothers and families rather who are losing their loved one in the ICU. It's the nurses who are standing in the gap. And it's because the nurse can at least hold the space for that compassion and kindness as somebody's passing in an ICU without their family near them. So I say all that to say that we know it's part of our training and part of our profession that we embed and embody and always operate from that place of heart and caring, which again adds to safety and adds to these intangibles that has studies show actually when there's congruence, people do better. Who would have thought? So we're in this kind of no man's land of we can't say categorically, but we're pretty convinced. And so for that reason, we push forward. Let's bring on and train the people who are willing to train the people we are most concerned about. And those are people of color, particularly Black women and Native American, Pacific Islander, and then Hispanic, and then marginalized folk, trans, and other people who are also marginalized in one way or another during their childbearing experience.
Does anyone have any questions for Jenny or comments? Jenny, thank you so much for your commitment to midwifery and your lifelong work and service that you continue to be so passionate about, and for the amazing wisdom you bring to us and insights. I mean, it's insights for practical change. We have joining us a special surprise guest, if you will. So a little change in our schedule before we get to Dr. Ramani. We have joining us Senator Tanya Anderson, who is the Madam Chair, I love to say that, the Madam Chair of the Georgia Legislative Black Caucus, and also a signer of Senate Bill 111. Senator Anderson, thank you so much for joining us.
Thank you so much for having me. I wanted to chime in so bad, but I had to wait my turn. I am excited about this conversation, as it is a very important conversation, and it should be a priority in Georgia, being that Georgia has the highest maternal mortality rate in the United States. And unfortunately, it is more than twice the national average. That's very, very sad. So Dr. Jenny, any partnership that you would like to have with the Black Caucus and any partnership from you to us, I welcome, as this has been an issue in Georgia, and now the light has is shining on this issue in Georgia more now than it has before. And I know that it is important to have midwives, and because of their instrumental role that they play in being first responders in the healthcare system, and even in the mental health space, because of mothers and what they go through and what they deal with and what they battle as they are trying to go through a cycle. And so that emotional support that midwives bring is definitely life-changing. And I'm supportive of midwives and midwives bills, as I am a product of a midwife. a birth. And my cousins in my very small town in the state of Florida were midwives to the community. I am proud to say I really didn't know how rich of a heritage and legacy that surrounds midwives, but I proudly say it. As young as I look, I was birthed by a midwife. And then there was not a lot of access to hospitals, and so midwives were frontline first responders, champions. And so I strongly support midwives as I've stated. And because I'm a Georgia legislator, I support funding it. I support educating our constitutional officers and colleagues. I support giving them a platform. I support that because I am a product, because I am a Black woman, because I fight for the issues of all Georgians, but the priority as a Black Caucus chair is that of Black and other people of color. So with that, I have to say that I am humbled to be in your presence, as well as excited to see the next level of what Georgia will do. We've put some funding in there, but we can do more. We can do more. We can give access to quality health care. We can give access to midwives so that they are not just, they're highly skilled, but they're highly trained professionally so that they can continue in their work and train others. Not that they're not on the same level, but so that they can have so that they are afforded the access that they deserve and the platform that they need to have their voices heard. And I choose to celebrate. I choose to uplift. I choose to support funding, support legislation, and to move Georgia forward. And the more that we can do that, the better we will be as a state, the better we will be as a medical community, the better we will be as a Black community, the better we will be as a community of women, all colors, all shapes and sizes, a better community of women to support and uplift one another. And so with that, I will continue to give you all a platform and an opportunity to say that we matter. What we bring to the table matters, and we'll continue to be a champion for your cause. So I thank you for this time and this opportunity to share with you, and I look forward to the work that we will do here in Georgia.
Thank you so much, Senator Anderson.
You're welcome.
I love all this energy. This energy is, I want to bottle this energy.
It's contagious.
It's so powerful. As the product of midwives myself, but in a different way, my teachers were and are still Sister Saran Henderson and Sister Nasra Smith. And the first midwife I met was in Roxbury, Massachusetts, Sister Shafia. And I truly can say that I would not be the physician I am had it not been what I learned about caring and attention to detail and listening and trusting my instincts and my intuition and the science. Had it not been for what I learned from the women I have been so blessed and fortunate to be a product of. Thank you for sharing and for your support of this shift.
Absolutely. Thank you for having me.
We have another incredible panelist to bring forward. Dr. Ramani C. Kelsey Rogers is a graduate of Spelman College, is a respected family physician from Columbus, Ohio, living in Atlanta, Georgia. She has a phenomenal bio. I've condensed it, but it doesn't even do justice to the incredible commitment she has to community service, to the military, and to her work as a physician. Dr. Kelsey Rogers served our country in the U.S. Army for 7 years and then remained in the Army Reserves upon departing active duty. During her active duty military career, she served as the medical director of the U.S. Army's Troop Medical Clinic and as the brigade surgeon for the 23rd Quartermaster Brigade in Fort Lee, Virginia. In 2005, she assisted in the planning and development of the active duty clinic at Kenner Army Health Clinic, and she became the clinic's supervising physician. She's highly decorated for her arduous, selfless service and her consummate can-do attitude. While working in the medical field, Dr. Kelsey Rogers developed a keen interest in research and in the advancement of healthcare. She spent a year as a researcher for Emory University, including developing prevention strategies for HIV in high-risk populations. Currently, she is the CEO of Kelsey Imhotep Wellness Incorporated, which provides contract medical consultation and care to both military and civilian entities. Her rich life in community service includes, and this is just a little encapsulation of what she is doing, sitting on the board of the Nguzo Sabe Center, Pittsburgh Center for Cultural Life and Education, and Sister, whose commitment is to educate, develop, and expose Reserve Officer Training Corps, ROTC women, to values and opportunities beyond the classroom. She's received numerous awards and recognition for her medical commitment and community service. Her greatest joy, she says, comes from her family, her husband Gregory, and children Greg Jr., Dominique, Safina, and Sadia. She also happens to be a mother and physician who chose to give birth at home. Dr. Ramani, if I may call you that, welcome and thank you for being here.
Yes, thank you. Thank you all for having me. And of course, right at the time, it's time for me to speak, Sadia has decided she's ready to eat too. So she's here with us learning, as is so important in the art and craft of midwifery, is teaching at a young age. So thank you all. And thank you to the legislators for recognizing the importance of having this option, this choice. And during this time of crisis, this time of pandemic, this time of recognition that's been said so many times about maternal mortality. And, you know, that's my physician hat on, and just reading articles, seeing the numbers in the hospital, going into rooms where someone is afraid because they heard about their cousin or the story on the news, or, you know, and wondering, is this going to happen to me? So I thank you all for recognizing the importance of this. And I guess just going back, I think about my father. He was born in 1925 in the Pittsburgh section of Atlanta. And so just hearing stories that he would tell us about his mother and Mrs. Humphreys, and the ladies knew who to call when it was time to have a baby. And, you know, it just seemed so simple to me then when I heard about it. But I grew to understand, although it's a simple concept, it's a well-oiled mechanism through dedicated mentorship and continuous education and just the reverence of experience by those who are taking that experience in. And so when I had my own OB panel, I used to tell my patients, don't worry, the baby's going to come. And that was a way for me to help their angst along the way. But of course, as a physician trained at University of Maryland, I had an MD, and I had that allopathic thought process still that I had to be there, even though I would tell them baby's going to come. But I felt like I had to be there to deliver that baby, to make sure, you know, I was in the process of getting it there. But so it was, you know, several years later that I really embraced what that meant. Baby's going to come. When I said it, that sentence kind of leans into the fact that this is a natural process. And we're just here to assure that the mom has everything that she needs, all the tools that she needs to allow this birthing to come. And I read somewhere that said, pregnant women don't need a doctor. They just need feminine power and wisdom. And that just gave me goosebumps even saying it, because that is what midwifery is. And so when my husband and I were surprised with baby number 3, as I say, our quarantine baby, we were 2 weeks into quarantine. But, you know, I knew that this was the grand finale. As Representative Tanya said, how young she looks, I'm sure I look the same. I look to be in my 20s or so, but I'm actually 48. And so this was truly a grand finale. And I wanted every step of it to be special. But of course, you know, I am a doctor, so I went back to an MD again, but was quickly turned off by the wait time to go see them. When she came in, she didn't introduce herself, came in, did her questions, and left the room. And I was like, okay, this is not special. This is not what I know that this pregnancy deserves. And I wanted somebody who was going to focus on the family, focus on what our needs are, focus what we wanted our experience to be, and kind of what our beliefs are and what our plans. And I thought back to when I was in the service, getting ready to deploy, and we were on a bus getting ready for some training, and there was an OB, because at that time they pulled everybody. We had an ophthalmologist, OB, family, just everybody. And she said, I don't know what I'm going to do if somebody has a heart attack in front of me, because the purpose of the heart is to send blood to the uterus. That was just like, that is so narrow-minded, just to have that thought process. And this is a person who brings life into the world, and you know, and that's her thought. And I said, okay, yes or no, we don't want that. I had to think about what was most important to our family during this period. And my experience with Safina, our 5-year-old, it was amazing. And part of what made that amazing was the midwife. And it was a hospital birth, but with C-Baby, which Dr. Boots Taylor, but the midwife is who was there during my birthing process and until the end. And I joke with Dr. Boots Taylor, he came in after everything was done to take a picture. And so, but it was because I was allowed to just birth, just have, you know, bring life into the world, and not directed by someone, not rushed by anyone. And I remember people said, ooh, you know, you had a natural birth. Oh my goodness. And I'm like, birth itself is natural. This is not this, well, it should be anyway, but that's a whole nother discussion. So the question, why did I completely transition to midwife for Sadia? She wants to be a part of the conversation. I wanted, you know, someone who's smart, someone who's intelligent, but of course, somebody who cares, and somebody who's going to be hands-on, somebody who's going to be there. And granted, I did, you know, start with an MD. Like I said, I turned right away. And there are 5 main reasons of why I selected a midwife and a home birth. And one was, of course, individualized care. When I went into the other office, I was automatically high risk, you know, without knowing anything about me, without knowing, you know, I eat very well. I work out with a trainer all the time, you know, several days a week. I've grown up with a garden. And so just knowing nothing about me, it was your age, you know, your race, your high risk. And so it was immediately them starting to calculate, well, we're going to have to do your, you know, test for gestational diabetes early. And we're going to basically plan intervention at 36 weeks. And we don't want you to go too long. So at 38 weeks, you know, it's just that whole, before we could even get to step 3, at 1 and 2, they're already planning interventions. And so that individualized care was very important to me. And my first conversation with my midwife, it was just beautiful, because she asked all about the family. She asked about the children. She asked just in depth of what brought me to this point. And as a family, I selected being a family medicine physician very carefully, I guess you would say. I knew that I wanted to be a pediatrician when I was young. And then I realized, well, to teach children, you have to know the whole family. So I may as well be family medicine, you know. And so then I went and worked with a family med doc and all that. But it was a similar approach. And just, you know, she wanted to know all of me, what brought me to this point. And so that was very important, that individualized care. And then the personal support to know that I could call whenever I needed to call. Of course, as a physician, we are able to have a little bit more access than the average person to docs. And so we can call or text, but I usually don't lead with the fact that I'm a physician. So a lot of times people don't know. And they just kind of discovered it along the way. But the postpartum visits as part of your care. So it's not just your birthing and then you're done, see you in 6 weeks, but it's true, genuine follow-up care. And then the support versus intervention. That is so very important. Again, my second birth was a hospital birth. And so there was continuous monitoring that they wanted to do. Of course, I said, no, thank you. But knowing that continuous monitoring is a pathway to intervention instead of just allowing birth. And we mentioned Safina and Sadia, but we had a pregnancy before Safina. She was born at 19 weeks and we named her Malika. So she came early. And I remember being in the hospital for that birth and not being listened to. And after my water broke, I mean, clearly I knew what was coming, but I knew my body was already in the process. But the doctors wanted to start Pitocin. They wanted to start, quickening the process and not allowing natural progression to occur. And everything worked out as it should, but just having that not being listened to, and it's like, I'm a doctor. How are you not listening to me? But it didn't matter, as we've seen with statistics before that have been already highlighted. And then our second pregnancy, I spoke to the doctor who was already planning for my intervention again. And then when I changed to C-Baby, it was truly a breath of fresh air, just the incorporation of the whole team and sitting and listening. And so then by third baby, the grand finale, as I called her, I was able to recognize that it was the midwife that made Safina's birth what it was. And I realized that the focus of the midwives was to allow me to experience my birth and not step in to deliver the baby. And that's so very important for women as they enter into this realm of their life, into mommyhood. And midwife stepped in when she was needed. Midwife stepped in when I needed her and didn't know I needed her. But just having that keen sense of wisdom and intuition and connection. And having that connection is only fostered in taking time and getting to know the woman in front of you, not getting to know the patient, but getting to know the woman in the family in front of you. And so her interest in my goals, my pregnancy goals in pregnancy, and whether someone wants a water birth or whether someone wants to do hypnobabies or whether someone wants their mother and grandmother and great grandmother in the room with them, the feasibility of all that. And I will, say, I did not necessarily want a home birth. I wanted a non-hospital birth. And I'm laughing now because my first thought was, well, I'm a realist and I am older. I don't live anywhere near a hospital. And so I figured just in case something happened, I wanted to be closer to a hospital. So I was going to go to a hotel and have the baby at a hotel with my midwife. And again, in those early conversations, she said, that's probably not the best idea. And instead of indulging me, she used that wisdom and that intelligence to redirect, listening to my plan, but redirecting that plan. And we still came up with a home birth that was comfortable for me. Now, I'll fast forward to the end. She actually ended up being born at home because she came really fast. So she had the last word, and we birthed right about a few steps away from where I'm sitting right now. And it all worked beautifully, but it worked beautifully because I was comfortable, had a plan, could call her directly, call my midwife directly. And so that relationship, which is the fifth and most important reason, of why I chose to have what was supposed to be a home adjacent birth, and but ended up actually being a home birth, but with the midwife. And so that the relationship is what can prevent, in my opinion, much of infant mortality, or maternal and infant mortality. The provider actually knowing who you are, what your limitations are, what your lifestyle is, and so how to step in and adjust that lifestyle in a way that you can manage it. Not just saying, stop eating this or start doing that, but here's how you can do it and how's it going. And so something that you can actually live with. So this was fostered in visits where we took time. It wasn't 90 minutes in the waiting room and then 5 minutes with the doctor. It was 5 minutes waiting and 90 minutes with the provider. And so just having that time to talk about nutrition and your relationship, and how are you doing and what support do you have, and preparing for that day. A lot of birth people prepare by going on Pinterest or going on the internet or something like that, but really preparing for that day, walking through, do you have everything? Let me see your birth kit. Let's go through it. This is what this is for. Know your body, understand your body. What are you doing with breastfeeding? Do you have the support for breastfeeding? Not the lactation cookies, but tea, and that has everything, all of those things, which are so important that I know, and I'm humble enough to say, I didn't have the tools to give to my patients when I was birthing children, years ago. And so I appreciate so much what midwives bring to the world, literally and figuratively. And it is crucial that we put an army behind our midwives to make sure that they are recertified and recognized as a legal entity, because we need it. I mean, the bottom line is we need it. It is imperative for me as a mom, me as a physician, as a consumer. It is imperative that we do whatever we need to do to make sure 111 passes and is a springboard to other states to normalize midwifery and help to normalize the naturalist of birthing. So that's kind of how I got to this point.
Dr. Ramani, thank you so much for your wisdom and intelligence, and so much just brightness that you're shining on this topic. The fact that you have had several experiences is so powerful, that you can really compare and contrast the care you did and didn't receive. And we know, going through medical training ourselves, I mean, people go into it with the best intentions. It's the system that's really set up to manage so much. One fact that I just want to bring to the discussion for those who might be listening later, who are making legislative decisions, is really important. We've talked a lot about access to care, and we've talked a lot about disparity. But the fact is that Black women have a almost 3 times higher maternal mortality rate, regardless of socioeconomic status. So right. If you are a Black woman with a PhD and an MD from Harvard, you're still 3 times more likely to die than a white woman of any socioeconomic background. As a birthing mom, how did you cope with knowing that?
Through preparation. Mm-hmm. Basically, through preparation. And what I mean by that is eating well, exercising, reading, and making sure I know how to communicate effectively so that I'm listened to. Because again, baby number 1, I was not. And then I learned, and I will say that through C-Baby, there was a lot of empowerment there. And when you put yourself around certain people, you meet others and you learn more. And so it just, you know, catapulted from there, and learning how to be comfortable to know that I wouldn't be one of those numbers, and knowing how to ask for help when I needed it, knowing where to go to ask for that help. And so that it is a scary number, and to know those stories is alarming, disheartening, saddening.
Thank you for being
And
willing to speak out as a physician and a birthing mother, because physicians who choose home birth can often be quite judged for that as well.
oh yeah, oh yes, absolutely, and I was.
Yeah. One of the other factors that, you know, you talk about the importance of advocacy and being able to speak up for yourself. And a lot of women, especially if they've spent their life disenfranchised and not heard, have shared with me when they do have to interface with the medical model, it can be hard to speak up for themselves. Mm-hmm. And I've had particularly Black mothers tell me that when their husband, if their husband is Black, tried to speak up to a physician, then they were treated a different way than had they maybe been a white father in a room approaching a physician, that there were the mm-hmm. anger issues and people got afraid. One of the things I think that's really important to know is that, unlike with hospital care, you have your baby with whomever's on call. If you are having a home birth and you do need to transport, your midwife comes with you and acts as an advocate for you. And that's a really important difference than in what right. medical model usually is.
Mm-hmm.
With postpartum care too, as a physician, we know that most women, as you said, see it in 8 weeks. But much mm-hmm. of the maternal mortality that happens isn't just in pregnancy or birth, it's postpartum. It's yes. hypertension, preeclampsia. How did you experience your postpartum differently as having a midwife than previously?
Big smile comes on my face. So I'm going to share a little bit of a video in a moment, but I'll just say banana bread. So I mentioned in a conversation with Mama Nasra, one of the 2 midwives who were attendants at my birth, I mentioned that I love banana bread. And so the day of my birth, she came and put some banana bread in the oven. So after I birthed, and again, it wasn't supposed to be at my house, but she brought it here when she came because she was already planning for it. And so my first postpartum, well, the call I think was like the next day, and they came by in 2 days. Mama Saran and Nasra both came by, and she brought me more banana bread. Now, what doctor is going to do that? But anyway, so all that's that personal relationship and being there. If anything's going, how is your latch doing? You know, how is Sadia doing with the latch? Do you have everything you need? What's your support? I'm blessed enough. My parents live right next door. But again, if you heard me, Daddy was born in 1925. So he's 95 and my mom is 80. So I'm not going to call them to come over and be here all the time and all of that. And so, you know, my team, as I call them, my midwives, and you see how I call them mine, because they make you feel like you're their only and not one of so many, but, you know, they were here, not 6 weeks after, but they came to the house, you know, and just checked, of course, you know, checked my uterus and just made sure I was safe and healthy. And I'll share with you a story of one of my, quickly, a good friend of mine. She had delivered her son in Washington, DC, and she had some blood pressure concerns, needed to go back to the hospital to be checked, had no one to care for her son. And so she was trying to basically make the choice, is she going to live or, you know, she didn't know what to do. So I made some calls. I called around and found someone she didn't know at all, but to come and meet her at the emergency room so they could provide, sit with her newborn baby while she went to make sure her blood pressure wasn't going to put her back. And she actually stayed in the hospital today, and the baby went with my friend. But she could have been home with no one to call. Think of people who had nobody to call, nobody to reach out to, and it's just home with a midwife. They're checking on you. Her doctor would have known nothing of this until 6 weeks later, if she made it into the office. And so having that critical time that you mentioned, postpartum, having someone who knows when to refer if they need to refer, and can manage some things on their own. That bridge that I heard someone speak of, but that bridge between home and medical care, or MD-DO care, but just that bridge of that could prevent so many bad outcomes. And we're talking legislation, decrease the amount of money that's spent by our government on some of these bad outcomes. And so if we're looking at numbers and dollars and all of that, it does make sense to support the bridge.
Does anyone have questions for Dr. Ramani?
I don't, but I want to say thank you for sharing your story.
Absolutely.
I have a quick comment. If I may, I just want to jump in here and just mention that, when we look at the statistic, that is that Black women, educated, affluent, good insurance, all of that, that's not protective. We know
Right.
Serena Williams' story.
Mm-hmm.
We know Kira Johnson's story. We know that these stories are across the entire cross-section and demographic of Black women and Black people. So what we have to really look at is, without these deeper measures, such as legislation, such as licensure, such as accreditation, such as training, without that, then we are back to having the mother individually fend for herself. So where Dr. Kelsey Rogers, you were able to get to that point where you could redress that balance and say, oh no, not this time. You were able and supported, privileged even, if you will, to be able to do that. And if you look at the masses of women and families who are not, and are victim to the system because they cannot find that way of, they don't have the power or the agency or the support or even understanding of what they have to do. What we're basically saying is we condone these women then and their families to have to be, it's on you, which is why those blame the women tropes are so dangerous, because, oh, well, if you weren't so fat, blah, blah, blah. If you didn't do X, you wouldn't have had Y. That's not true. And we must dispel those myths, and we must act to dispel them by putting stronger, more protective structures in place across the board for everybody, so that the access is to that. The access is to the fact that there's a C-baby practice or a midwife practice on every corner, that every woman doesn't have to struggle to find what you found, Dr. Kelsey Rogers, because of your own abilities, your agency, your power, your support, your love, and your family that was there for you and is still there for you. We have to keep in mind, this fight is for the people who don't have that and will never have that unless we act.
Right.
Thank you, Jenny. I know that Representative Park Cannon would like to speak, and then I believe we have some video. It sounds like Dr. Ramani, you have some video to share. I don't know, Missy, are you still here? Representative Park Cannon, if you would like to jump in, this is a great time, then we'll figure out how the video is happening.
Awesome. Hey there. I hope my audio is okay. I left the Capitol. I just had to get home. Normally, I'll take meetings when I get home, sitting on my birth ball. I am a labor doula and, was in practice and community with Karina. I am co-working. So if you hear background noise, just know it's all good stuff happening at the same time. But, you know, during legislative session, I try not to schedule too many clients. And I just scheduled my first birth for after session. It's going to be in June. I'm super excited. And until then, you know, as you spoke to, Doctor, we're on a regimen of walks and water and just conversation. And as a legislator and doula, I really just try to help bridge that conversation with the lawmakers too, to make it really clear that there is a pathway towards progress for positive outcomes. And that is more of a whole health model, more of an intricate care model, a survivor-centered model, trauma-informed model. And we have a ways to go. You know, I do think that there's some hope in some of the rural legislators who admit that they, you know, too, and their families have revered home care, home birth, because that was the only option, whether that was because of location or because of demographic. And there's some really stark realities that we can still take note on here in Georgia as it relates to people's access to health care. I think that it was said very clearly a few years ago that, you know, some of our leadership has been too cheap to provide Medicaid services at times when it's necessary to the people who need it. And we took that narrative and brought it towards the Mama Medicaid conversation. And we did get 19 million in last year, but we had requested 40 million. And we wanted 1 year postpartum, not 6 months, you know, to give families and communities that wraparound care. So I think that it's really appropriate to have y'all today speak to us. And, you know, I made announcements about this and members know, and they've gotten additional emails and they're interested and intrigued to just continue to hear from you about the ways in which we can legislate positively forward. Last year, we really had to say the terms maternal mortality over and over and over. And I'll have to be honest, as a, you know, legislator doula, I was like, we're adding trauma, you know, to people by just keeping on saying these numbers. But we have to say these numbers and we have to put these facts out here. So this year, I am sponsoring a doula reimbursement bill. It would be $500 per birth on Medicaid. Additionally, we still have the Working for Two Act, which is all about pregnancy accommodations in the workplace, because Georgia loves to be the #1 place to do business. But we got to talk about our workforce, and really economic mobility of families is grounded in sometimes the birthing person. And the last bill is our Dignity in Childbirth bill. Representative Abel Mabel Thomas, who just finished her long career in public service last year, she really helped bring this conversation forward to say, if we want to talk about implicit bias and explicit bias in healthcare settings, we can do that. We can ask the Department of Public Health to work, you know, with healthcare professionals to provide that access at no cost or at low cost to those agencies and communities that they serve. So this year we have refiled that bill. The Health and Human Services Committee has been very busy, and we spent a lot of time working on the Medicaid issue this year that I think will help us next year. But we do need more support on the conversation around implicit bias training in childbirth and healthcare settings. So thank you all for being here.
Thank you so much for the work you're doing for mamas. That's amazing to be a doula and a representative at the same time. What a powerhouse. Thank you. Dr. Ramani has a video. And then if anyone has further questions or comments, I believe we're scheduled to wrap at 4, and I don't know how long the video is, but I am going to just say how much I really appreciate the work that the legislators are doing, the senators, the representatives. Thank you for being here. Thank you.
We actually have 2 more. We have our leader, James Beverly,
Oh, beautiful.
We have our minority leader in the House, James Beverly, Representative James Beverly, Representative Derek Mello, and Representative Shay Roberts. So we want to give them an opportunity to speak because we have a Georgia Legislative Black Caucus meeting in 15 minutes and I have to go, but I'm going to stay on to let you know I support you. And the partnership with the Georgia Legislative Black Caucus is one that you can count on.
Wonderful. Let's go in that order, and everyone can unmute themselves and introduce themselves. James Beverly, then Derek Mello, and then Representative Shay Roberts. Does that work for everyone?
That works. Good afternoon, everybody. As everybody knows, we have a jam-packed day today, and it is so good to be on this call. You know, y'all don't know this, and I don't think anybody knows. It's going to be now public information. But my first son was delivered by a midwife. And so, you know, and he's now 24 years old, graduated from Morehouse, now working at Facebook. And so it worked out. And he's a little bit of a nutcase, but the next two didn't. But anyway, I digress. Happy Community Midwife Day. I'm just so happy to see you guys. We appreciate what you do. And, you know, whatever the Georgia House Democratic Caucus can do to support you, we certainly will. And all the work that obviously that Representative Park Cannon is doing. She's my sister, my friend. Mabel Thomas, the work that she started, certainly the Georgia Black Caucus, and then Derek Mallow and Shay Roberts. Those are two outstanding legislators who I'm sure y'all will hear a lot more from over the next 10 years when I'm somewhere at the beach relaxing. I love you guys. I got to jump to another meeting. Just wanted to say hello and that we firmly support you. I'll see y'all later.
Representative Mello.
Oh, I didn't know I was in what the order was. My name is Representative Derek Mallow, and a fun fact, my grandmother, I'm from a small town in Savannah, Georgia, known as Pinpoint, Georgia. And my grandmother, one of the first things that she did as a child is she was a catcher. And the job of a catcher was, as the doula would help to deliver the baby, you had a young person who would be underneath as they stood up on the birthing stool to catch the baby. And her first job when I was a kid was telling me about being a catcher. And so my family is a Geechee Gullah family. We have a rich history with using midwives in that process. Many of my mother and many others were born at home. And their birth certificate says home. There were no hospitals until the Telfair Women's Hospital would open and deliver babies of color. And so just share that with you all. Rich history. I'm proud to support you in the work that you're doing. And moving forward, of course, my good friend, the Senator Tanya Anderson and Lester Jackson, Doc Jackson and Senator Anderson doing great work on this. So happy to support you and proud to know that Representative Park Cannon is a doula. And so glad to circle the wagons with you all today, and I'm glad to be here. So thank y'all so much.
Hey, everybody. I'm Representative Shay Roberts, also newly elected. I don't have that interesting of a story. I love that story, Derek. But I'm having a lot of fun. I sit next to Derek up in the gallery. And so I'm learning a lot. I'm so supportive of the work that you guys are doing and excited to hear more about Park's work. That's awesome. This is really important stuff. And if there's anything that I can do to assist, y'all let me know. And I'm just happy to be here. Thank you.
Thank y'all so much. It's really so heartening to see the support and to really feel the potential for change. And I feel like, you know, if anything COVID has shown us is, and Jenny brought this out so much, I mean, we can mobilize for change and the resources are there and the energy's there and the intelligence is there and the wisdom is there. Speaking of, I will turn this over to Dr. Ramani for her video. And then I believe Missy will pick back up and bring us home. Thank you so much, everyone, for making the time to be here and for allowing me to be a small part of this day. It's a real, just a gift of my life. I was talking on the phone with Sister Nasra last night. We had a long chat, and she was at my first birth 36 years ago. She and Saran were my mentors, and yeah, it's just an honor to be here. And my 4 children and my husband are all Georgia born and raised, so I'm a New Yorker, what can you say? But I lived down there for 18 years, and so that's where my midwifery home is. So thank you so much for letting me be part of this
Yes, and
Dr.
the video is short because I fast forwarded past the birth since we're in mixed company and all. But it allows all the representatives and all of our honorable, I guess you'd say guests, I'm a guest as well, but everybody to kind of see midwives in action and what, why this was the right choice for me. So I'm gonna share screen. Should be, there we go. There we go. Ignore the singing. Okay, so as you can see, that experience is priceless. This is why it's so important for us to do whatever we need to allow midwifery back into the normalcy of our society. So Hopefully that just added a little personal touch to show you what it can be for moms who choose that. So thank you for allowing me to share.
Thank you so much for sharing that. It is always a pleasure to get to witness the sacred moments of somebody's birth. As I wrap up, I'm going to attempt to share my screen just for some final.
Dr. Rahm, we have one more state representative to join, Representative Beth Moore, and I have to get off. I have 5 minutes for my call.
Yes. Missy, can we allow room for that?
Sure.
Great.
Who said that?
All right. Can you all hear me?
Yes.
Hi, everyone who's still on the call. My name is Representative Beth Moore. I want to thank my colleague, Representative Park Cannon, for organizing today and getting the word out. I know you guys have been on here for a long time, so thank you. Thanks for letting me intro right at the end. I am in the car driving, but I am safe and hands-free, so I'm going to leave my camera off but talk to you guys. I really appreciate this advocacy group so much because when I was first elected to the Georgia State House in 2018, I really had no idea what the midwifery industry was, what the challenges were in terms of, its status in Georgia state law. And you guys educated me. And you were incredibly forthcoming as to the status, the challenges, the history, and all of that is incredibly necessary because those of us who serve, we are citizen legislators. I am not in the medical industry. I'm an entertainment attorney. If you want to talk about the film industry, I'll talk to you all day long about that. But when it comes to specialized issues like what you guys are facing, you guys are a critical part of that educational process. And I really just commend everything that you're doing, everything that I've heard, about what you're seeking to do legislatively. I find very compelling, and even with an understanding of what some of the underlying challenges are. I recall that some of the arguments against midwifery is that, well, it's dangerous. It's much safer to have a child at the hospital. And I'm thinking like, well, Georgia already has one of the worst, maternal mortality rates in the country. So I don't know how much worse it can get. So I really do appreciate everything you guys are doing. Consider me an ally. Please continue to educate me, inform me so that I can use the proper language and pursue the same policies that you guys are interested in. And I look forward to keeping this conversation with you all going. Thank you so much.
Thank you so much, Representative, for your support and your thoughtful words. It's just wonderful to see the support continuing to pour in and just really inspiring and also quite hopeful. Missy, I'm going to pass to you to close with your the next part of what you have, and then to close us all out for the day.
Yeah, I was just trying to take some notes from everyone that was speaking today, and I've quickly put some of our facts together for us right now, just to hit the highlights for Georgia. We have the worst maternal mortality rate in the United States. And we know that 60% of these deaths have been determined to be preventable. We know that access to maternity care is a problem for Georgia families. 50% of our counties are without access to OBGYN in our hospitals, and community midwives are mobile healthcare units. If you could see the trunk or the back seat of a community midwife's automobile, you would see a pulse oximeter, you would see a fetal Doppler, you would see even portable ultrasound machines. We are armed and we are ready to go where there are no hospitals, where there are no care providers, and we're trained to do that. Midwives are able to save Georgia money. Washington State has done a fantastic job tracking this. They've saved almost $500,000 just in cesarean section reductions alone over a 2-year budget cycle with licensing their midwives. They're one of the top states for integrating licensed midwives into their healthcare field. We also know that insurance companies such as Cigna are now covering out-of-hospital birth with midwives who are licensed by their jurisdiction. Georgia families are not able to be reimbursed by their insurance companies currently because midwives are not licensed by our jurisdiction. So that is one thing that I know that Georgia families would really appreciate. And 54% of Georgia births are covered by Medicaid. So we know that we need Medicaid expansion. We need Medicaid to cover community midwives so that we can save the state money, so we can save Georgia families' lives. And that's all today. Thank you so much for your time, everyone. Just the support is unbelievable. Midwives give so much. I had 5 births at home with a community midwife myself, and then went on to become a midwife because of the difference that made in my life. So I really thank all of you for your support. I hope you got a lunch and enjoyed it. We welcome feedback, we welcome more questions, and we hope to see you again.
And thank you, Jenny, and Dr. Ramani, also for being here with us today. Jenny, from your busy practice, and Dr. Ramani with your family and practice, to take the time to be here as guest panelists. Thank you, everyone.
Thank you.
Take care. Be well. Stay safe.
Thank you.
Bye.
Thank y'all for your work.
And thank you, Aviva.
Oh, pleasure.
Thank you. It was wonderful. Thank you. Bye-bye.
Bye, everyone.
Thank you, everyone.
Thank you, Ramani.
Bye.